Hi, everyone. Welcome to the CG podcast, where we explore the legacy of the COVID-19 pandemic on science, society, and public health policy. I'm delighted to have my guest here today, Rajiv Bhatia. Rajiv is a primary care physician associated with the Stanford Medical School. He's an internationally renowned health system innovator, including in the field of health impact assessments. And for over 14 years, he was former deputy health officer at the San Francisco Department of Public Health, where he responded to previous pandemics like SARS-1 and H1N1. So it's great to have you on the podcast, Rajiv.
Yeah, thanks for having me here.
Great. So you were intimately involved in COVID and also in efforts to challenge in California, where you're based, efforts the state of emergency and to promote reopening quite early on. So I just want you to describe your experience as COVID is starting up and lockdowns are starting up, and sort of as a public health officer, what that was like.
Yeah, I mean, I was intimately familiar with California's public health rules and laws, and my reaction when I heard that the health officers had decided to order everyone to stay home was pretty much one of shock and surprise. Certainly, COVID was a serious, issue. It was a life-threatening issue, but this was it seemed to me immediately this was a step that was taken that was unprecedented, that didn't really have any supporting evidence behind it, and that would have untold consequences. And what was surprising is that this decision had been made with like almost no process. In public health, and I've had experiences both with infectious disease and pandemic management, but also with other public health policies. Every time we try to move a public health goal forward, it's a struggle, it's a fight. There are pros. We recognize there are downsides and upsides. There's winners and losers. We are trying to move things towards the greatest common good. And there's always negotiation. There's no one kind of right answer. We have to bring strong and to move it all, we have to bring pretty much incontrovertible evidence that what we're proposing is going to work. And then there are the downsides. And then we need to argue that the benefit from this thing that's going to work is greater than any of the downsides. And it was pretty obvious to me that there were untold downsides that were just not being considered. I mean, what happened in California was the 6 public health officers, and I know them all, they were colleagues, while I was at the San Francisco Health Department. They met over a weekend, and they decided that this was to be done. And because of a fluke or a quirky law in California, their lawyers told them they had the legal authority to do so. And then they just went ahead and pulled they went ahead and pulled the trigger. But and we can get into a little bit more of this, but what were the consequences of keeping people at home? Would it stop the disease? What was there evidence that would that it would stop the disease or even slow it down? And what would be the consequences of keeping people at home economically? All of these things that have kind of been raised. They fundamentally didn't have the capacity to answer the questions.
Yeah,
and they made that decision.
Right, and you're acutely aware of this with a background on health impact assessments, right? Which is to look at the impact of, there's lots of different methodologies there. But did you have a chance to talk to any of these former colleagues during those early months?
I did. I mean, my colleagues for San Francisco had become the state health officer and the deputy state health officer. So these decisions were being made by them with Governor Newsom, and I was having honest, frank conversations with them. And early on, they were, after the initial stay-at-home order. They were deciding what to proceed next, and there were options on the table. They were considering taking a targeted approach, where they would be there. It was on the table. People had proposed internally, but again, this is the core. I mean, in public health has established what we thought clear rules for making policy decisions. Bring the evidence to the forward, make it transparent, right? Have a public process. But all of this was happening behind closed doors, and secretly, right?
During a state of emergency, right? So that changes the sort of the criteria of decision making.
It doesn't. No. You can. It is. Again, the state of emergency in California. What's that about, right? So, are you familiar with the state of emergency law in California?
I'm not the specifics of it. I have a feeling you are.
Yeah, I mean, so basically there are two criteria to declare a state of emergency in California. And it can be declared by a public health officer, an individual public health officer in a county. It can be declared, sort of at the state level. One criteria is that there's an overwhelming public health threat or crisis. Okay. I think that given what we were seeing in China, in Spain and Italy, given what we were seeing, you could make the argument that we had an imminent serious public health threat. The second criteria is the necessity of mutual aid. One county needed to come to the aid of another county.
Right.
Okay. That criteria never materialized. So the state of the health, there was potentially a threat that because of hospital overutilization, counties would need to support each other. People would have to be transferred from one hospital across county lines. That never occurred. There was never any hospital capacity issues at all in California.
And you need to fulfill both criteria for it to be a legitimate state of emergency.
Correct. But who is there to challenge it, right? If public health officials applied this law incorrectly, and give them the benefit of my colleagues and I, we said, we'll give them the benefit of the doubt in a time of uncertainty, make a decision, but then in a couple of weeks, reevaluate it, bring the evidence to the table. See if you meet the criteria, but they didn't do that themselves. And legislators, I mean, their authority comes from California law. Legislators were not experts and didn't have the confidence to challenge experts. And again, there was overwhelming media and social media. There was overwhelming public fear that allowed these decisions to sort of continue to happen.
So surely somebody challenged the state of emergency because it didn't meet those two criteria. Were there any court cases, or how would
no? There were. I mean, nobody challenged the state of state of emergency. I mean, I think that was an arcane, public health law. Nobody thought to dig. I mean, Jeff Clauser and I, we wrote an article, and we could only, we got it published in some web forum, online web forum. I think we were correct, but being correct doesn't change things. Like, it was just overwhelming political opinion was not to challenge anything, and it was overwhelming groupthink. I think in this case, I don't think anyone's gone back and said, California health officers, did you actually follow the law here? Did you ever, I think there's an argument to be made, and I think the public should be aware that the criteria wasn't met, and that's something that's very important for when you're gonna, for the next time.
Yeah.
You know, what was done according to public health ethics and rules and practices, and what wasn't. I think that's still buried.
That's a really good point, and I'm really quite curious about this. And I'd like to follow up with you. But now, getting to your point, so you have the lockdown, the state of emergency, and you're saying, okay, we can give public health officers the benefit of the doubt. There's a lot of uncertainty. We reevaluate things in a few weeks, right?
Right.
Why wasn't that few week reevaluation done, or what were
Well,
some
I can
of the
tell you.
factors that
I mean,
inhibited it?
I think that's I mean, I can tell you what I did and the responses I got. So,
Okay, good.
I mean, one thing that I was doing, you know, immediately was asking my county health departments for the data. I said, give me the data on your infection rates, the contact tracing, hospitalization, you know, counts at a local level, so we can look at this. A couple of colleagues and I said, you know, I just said, I'm going to look at this. I know how to look at it. And but I was stonewalled by, we have public records requests. I don't know if I'm sure there's something similar in England. I was being stonewalled on those public records requests. What I found out behind the scenes when I was asking for contact tracing data, that it didn't exist.
Okay.
So without the contact tracing data, we had very little. There would be no information on where and exactly. You know, we knew case counts, we knew hospitalizations, but we knew nothing about exactly why, and you know, where was transmission happening. We suspected it was mostly going to be within home transmission, right? And that would be an important point to make, I think, to the public. And I think that if we had that data, we would have found that 80-90% of transmission was happening in the home. That would have given a sort of a different narrative. The narrative that was being put out by public health officers was that this was community transmission. Right. That now, sure, there was, you know, how did the disease get into the homes? People had to go to grocery stores. Some essential workers had to go to work. Right. So there was enough. So this wasn't, people weren't fully quarantined. It was a leaky quarantine. Right.
Exactly.
And a certain subset of the population was sort of the leak. They were bringing it, bringing it home, and then everybody in the home would be exposed, right?
Yeah.
So, we weren't able to sort of get the facts on that to make, make that case. We looked at, we were able to get hospitalization counts, and what I was able to sort of see, at least in the first wave, is that the first wave peaked at the same time as the shutdown order. Exactly at the same time. And I think you saw the same, similar findings you saw in England and, in other places. Certainly there were other waves, but there was no evidence that the shutdown stopped, really changed the dynamic. And I think that was a hypothesis we had, and we were looking for evidence in order to, not to challenge, but to critique, to evaluate that hypothesis. And this is another, I think, sort of persistent theme. There was a statement of truth made by public health officers that wasn't based on evidence. Okay. And it was promoted as truth, whether it was shutdowns, flatten the curve, whether it was masks stop transmission, whether it was school closures are critical, whether everything in the first year pre-vaccine was a promise, right? A non-evidence-based proclamation that nobody was allowed to challenge.
Yeah, a form of wishful thinking. But surely the public health officers, like if you put yourself in that position, right? You were in these roles previously. They were looking at the data and they were aware of this discordance between what the public was thinking, and then in the sort of media sound bites, and then what the actual data was saying quite early on, I would imagine.
Well, I don't know. I don't know. I mean, first of all, they didn't really, I mean, I mean, we're jumping a little bit, but it was maybe July where so the data. So in California, the data is collected at the county level, and it floats up to the state. Every time there was a case of COVID, there is supposed to be a case record. That case record has a form. That form has facts about where the person lives, what occupation they have, facts that allow epidemiological analysis of the profile of the case. What we were suspecting was that this was not happening. That basic case investigation was not being done, and cases were there was overwhelming numbers of cases, but it could have been done for a sample, a random sample in order to get. So we weren't profiling anything about the epidemiology. We weren't following our own protocols. What colleagues and I did was we asked the state to release the de-identified, without personal information, facts on the case records for all of California. And we said, well, you guys are not doing the analysis. Bring the academics in and let us do the analysis, make the data public. There were 12 prominent epidemiologists at all of the, at universities, public and private universities across California. We co-signed a letter. We sent it to the governor and the state health officer. And we were told, no, we're not going to release de-identified data because it might violate some privacy rule. I mean, it was a ridiculous argument that we got back. We countered with, well, don't give us individual level data. Don't give us the exact age. Give us the 10-year age window. I mean, we know how to manage this problem of privacy. And again, we were said no, and we had no recourse.
Yeah. So I mean, in some ways, this is hard to believe because you have a huge staff, right? I mean, there's a lot of epidemiologists that are employed by the state. And so what are they doing if not, crunching and analyzing epidemiological data from different angles to make sense of the nuances and the specifics of the transmission of the most important outbreak in America for 100 years? I mean, it's a little baffling, no?
I think it's baffling. I think so. So first of all, I don't think the data was collected.
Okay.
Right. I think they were just processing case counts.
Okay.
Right.
So
large, and we knew what to do here. We knew that when you have a novel virus, and honestly, I mean, my opinion now in retrospect is that there was nothing to do to change transmission.
Right.
This was a virus that started transmission pre-symptomatically. The generation time was quick, a couple of days. Right. So there was nothing to do. There's really nothing to do. It is going to infect and transmit. And until, and
it was introduced earlier than we thought as well in California, right? As elsewhere.
Where and when it was introduced, there was nothing, this is an unstoppable virus. Yeah. As viral as many respiratory viruses are. And that should have been communicated to people, honestly. And now we're sort of switching gears. A different approach would have been targeting the vulnerable, right? And drawing, multiple fences around, how could you have multiple fences around the most vulnerable? You didn't have to keep kids at home. Did kids have to go visit their grandparents?
Mm.
Was that necessary? Would kids, if you had said, even without an order, hey, kids, don't go visit your grandparents. Hey, grandparents, don't be around your kids. Let the kids go to school. Would people have broken those rules? No, people would have followed those rules voluntarily and did. You didn't need a rule for that, right? So,
sort of,
yeah, I mean, things did not make sense because there was obvious solutions to optimize this situation. Kids weren't vulnerable, keep them in school.
So if we go, I mean, this point of there's not much we can do to actually stop community transmission, which I agree with. It's also a very difficult thing when you're in a position of power, right, as the public health department, to say, hey, actually, we can't stop this tidal wave of infection. There's these things that we can do, but we can't eliminate the disease. Did something change in the culture of public health? If you go back to, let's say, H5N1 or even in bad influenza years, 20, 30 years ago, when we did have that public communication, did something change itself in the discipline, or was this purely a groupthink that emerged out of sort of the domino effects from China and the media headlines?
I don't think anything changed in the discipline. So I think public health as a culture would like people to behave.
Yeah.
Right? In ways that they think are optimal for health. They'd like people not to eat fast food. They'd like people not to drink. They'd like people to exercise. They'd like people to get vaccinated. They want all of these things. Okay. They've historically not had the power,
right,
to force this upon anybody.
Right.
And when they make attempts to force people to do this, they get pushback appropriately, because lives are lives. I mean, freedom matters more. Freedom matters, right? For people. People value living, right? And enjoying life. And it's perfectly reasonable. And we make everybody makes trade-offs. Public health doesn't have the right to take their own internal values. These are values of people who have decided to be public health officers, and I'm one of them. Right? We don't have the right to take my value and impose it on the rest of the world. Right? My trade-offs. And this is what public health ethics said about policy. You need to have a compelling reason to act. You need to have evidence. You need to bring it to the public. You need to look at the pros and cons, and it needs to be a collective public decision, a democratic decision, not an order. But in this moment, there was, and I don't even know if there was a political demand. I don't think Gavin Newsom was saying, "Hey guys, I want you to do something now." Gavin Newsom and the other politicians were blindsided. They were looking for the best possible advice. I know my former colleague and supervisor at the San Francisco Department of Public Health, the person who advised me, was in a prominent position in a major U.S. East Coast city. And he advised the mayor not to shut down the schools. Okay. That recommendation wasn't made public.
Okay.
Right. So he's an infectious disease specialist. So these,
and was it taken by the no, it wasn't. Right.
No, because it was an overwhelming kind of tidal wave of, and I mean, you can see even the Republican the Republican leaders, they went with this because they're not experts. They weren't in a position to second guess this in the moment.
So getting back to the epidemiological data systems, do you think then, if California was collecting contact tracing data, right, doing these targeted epi studies early on, do you think that would have pivoted the response and we would have had we would have made a difference? What do you think?
If it was transparent, yes. Okay, because I think that we would have seen, for example, how much community what is the percentage of transmission happening kind of randomly in the community versus what's happening in the home, which workplaces are most affected. Would it have changed the trajectory of the virus, the wave 1, wave 2, wave 3, wave 4? No. I don't think anything would have changed the trajectory of the pandemic.
Yeah.
Okay. I think it would have changed it would have made our policies different. For example, we may have had more data sort of target, and research interventions in particular workplaces where transmission was happening more frequently. There is a, as you know, about 80% of the deaths occurred in the elderly and the frail.
Yeah.
90%. I had healthy 80-year-olds that had COVID without any effect. It was the unhealthy 80-year-olds, the ones that got sicker.
Right.
There's one of the largest nursing homes in California is in San Francisco, Laguna Honda nursing home. It's a public nursing home facility. In the pre-vaccine first year, no deaths. 1,000 residents, the largest in the state, because they had meticulous infection control.
Right.
You had other nursing homes, fly by night, operators, corporate operators, low staffing. Staffing from nursing home was working in one nursing home in one day, another nursing, right?
Yeah.
And there were so many things to do to focus on targeted strategies for the vulnerable. We could have turned our attention there.
Yeah, which also have their own trade-offs and side effects, right? Of incredible infection control in nursing homes, right?
Yeah, and maybe and again, it might have had limited ultimate utility, but at least it would have been more evidence-based than the blanket, blunt, keep everybody at home approach.
So do you see? It's quite surprising that California, a wealthy state such as it is, wasn't collecting basic epidemiological data during COVID. Have you been?
And they weren't doing doing any contact tracing.
Exactly.
No one was. They were saying, well, we can't. What they were finding was they just, I don't know whether it was staffing or nobody would participate. There were all sorts of barriers that they said to do it, but they weren't. And in that situation where contact tracing is one way to get fine-grained epidemiological information. The other way is to do a sort of a community cohort study. Right. There are well-defined methodologies to look at a novel epidemic. We didn't do them. We simply didn't do them.
So since then, have you been part of any conversations or seen that public health in California is implementing or reforming or addressing this problem of capacity, so that if we had another COVID, we would be able to do basic epi studies, during surges or as we're making these decisions?
I don't know. Okay. I haven't sort of seen it. You can count how many epidemiologists are employed by the state. Hundreds. Yeah. Right. And by the counties, hundreds collectively. Right. There was no, was there a shortage of money? If any state had said, there was money pouring from the federal government to the states. If the state, if the states had said, we want money to set up a formal cohort study, would it have happened? The cohort studies were, I think, post-vaccine set up by the CDC. There was one cohort study. I don't know if it's called the PROTECT study or there was one cohort study and it was in children and adolescents, right? Where they're doing weekly surveillance with testing, right? And looking at the epidemiology of the disease and looking at the effects of the vaccine. Right. That's a multi-center study set up by the CDC. We had the infrastructure, we had the smarts, we had the infrastructure. It was done in previous epidemics.
Right.
Why it was in there are pandemic plans. It
Yeah.
all calls for doing this. So
Right.
it was a failure to follow our own plans.
And just to be clear, I mean, these types of studies were set up probably in late 2021, I'm guessing, or into 2022 is my guess. And the other point is, this isn't just your conjecture. I mean, you did write a paper. I think it's called "Missing Epidemiological Science." It's in PLOS One, right? What's the title again?
The missing science. I don't have it. It's in PLOS. What we did was we looked at what studies were done by government agencies.
Yeah.
And what in of the studies, how would you categorize them? Were they hypothesis generating? Were they like case reports and case studies? Or were they analytic, looking for a particular, looking for a particular answer? And what was the methodology of the studies? Most of the studies done by government agencies were case reports and case studies. They were conveniently found groups of cases and a description of who was in this bundle of cases. And they didn't really, they kept happening in year 2 and year 3, and we didn't really learn. We didn't really learn much from them.
Right. So they would do contact tracing around a particular outbreak event, like
no contact tracing. There were very few contact tracing studies done in the U.S., and they were all very small scale. There was no coordinated national analysis of contact tracing data coming from a systematic approach applied in different regions.
Okay. I'm thinking particularly of some of the CDC ones on the East Coast, like the choirs or certain bars or
that's
clubs.
Not a contact. That wasn't contact tracing. That was simply a cluster. They found They found that 2 or 3 cases happened surrounding an event, a choir, a motorcycle group, college students going to Mexico, kids going to summer camp. And it's very interesting to me, and again, I don't know the motives of the people behind this, but and back to the methodology, they found that 2 or 3 cases happened, and then they decided to say, okay, who else was at this event?
Right.
Okay. So now they find, there's out of 50 people at the event, 30 people got COVID.
Yeah.
Okay. Was it significant? Kids at summer camp all had, viral respiratory infection together. Yeah. Was that important? Yeah. But what it did was it was part of, I would say, fear generation. It's happening to the kids in summer camps. It's happening in daycare centers. It's happening, it's happening at motorcycle parties. It's happening at basketball games. It's, it's everywhere, and you can't, and all of those were community, were there articles that were saying that in the home where nobody's wearing masks and you're hugging and, your family members, look, you're going to get infected. And that's normal, right? You have a viral infection, you bring it home. People are not saying, so, Johnny, stay in your room for 5 days.
So what would you have liked to have seen in California in March, April 2020 in terms of a good, solid contact tracing infrastructure, let's say, or study or series of studies?
Okay. I think, recognizing that the number of cases were overwhelming, you would have set up a cohort study, right? And you would have taken taken a couple of sites, and you would have sampled people at those sites, on a regular basis. People would have willingly participated. You didn't have to do 100%. Again, we can sample things. You would have done deep contact tracing. If you're getting an overwhelming millions of cases in a year and you don't have the capacity, you sample. Right. And you would still get robust data on what is the risk of forward transmission in community settings versus home settings.
Yeah.
I think at some point you would have used that data to sort of target the response. You would have not been making people panic based on case counts, because a case count is a laboratory evidence of a exposure or an infection, without any that might have been a past infection, or without evidence of a clinically significant event. You would have been tracking hospitalizations and where they were, and focusing, maybe focus. If hospitalizations, the whole theory of shutting down society, and with all of the attendant consequences, which I'm sure you've discussed with others. If the rationale for shutting down society was that hospitals would be overwhelmed, ICUs would be full, and we wouldn't be able to provide the care, right? That was the rationale. That was the argument. If that never happens or never comes close to happening, you don't need to shut down. That was the argument I kept making. You're not approaching capacity.
But rather what we saw is this entrenchment, right? And in fact, in terms of even epidemiological science, I've gone to a number of conferences recently in the UK and elsewhere in the US, and with senior epidemiologists and professors of epidemiology, and they are arguing actually that the COVID measures that we implemented were very effective at stopping community transmission, and they cite different studies, right, that sort of support that. I think that those studies are poor quality, and I would imagine that you do as well. But there seems to be this argument in the discipline itself, actually, about what happened during COVID, right?
But so stop. Okay, so let's be careful about this. Stop, delay. I mean, ultimately, what happens here? We all get exposed and infected, right? Does any epidemiologist think that nearly 100% of the population who doesn't live kind of on an island in Scotland, in a bubble, that they didn't get exposed or infected during this? We all got exposed and infected. Nothing stopped it. The goal was to delay or slow, perhaps till the vaccine came out. That would be one reasonable, that would be one arguable goal. But the goal was to slow it down enough to be able to manage the consequences. Keep the hospitals open. Right? Keep the hospitals keeping the health system to be able to sort of manage the capacity.
Right. I mean, the reason that I was bringing it up is it seems to me that there's a sort of a crisis right now in epidemiology itself related to the COVID response. So people will pick certain types. You can sort of move numbers around and methodologies and whatnot in different ways to show different effects and argue, that certain policies were effective even though they weren't really effective in the real world or whatnot. So
or
it seems
you can
like there's
believe
this
things
need almost in the discipline.
Sure.
Yeah,
or you can believe things, right?
Belief.
Like the election was stolen from me, right? So, you can believe anything.
There seems to be a strong belief in epidemiological science right now that what we did or what was implemented was needed and was effective, and this idea that actually community transmission wasn't preventable in that larger sense, and that it was a fool's errand to implement all of these policies. That's very difficult to swallow, right?
Right. So if you're a person that took away people's liberties, who suspended the Constitution and took away people's liberties, that's not a small act. It's not a trivial act, right?
Right.
And I mean, and then or let's say you're a surgeon and you said, there's an infection in this arm, I need to cut it off. And you find out there's no infection in the arm. You're probably going to want to believe there's an infection in the arm.
Right.
You're probably going to want to believe, if you've done something like this, you're probably going to want to believe that you did the right thing. It is, what is it? Cognitive dissonance. It's too much cognitive dissonance. right? And you have enough other people saying the same thing, so you can look at them and say, we did okay, right? We did the right thing. I mean, there's something about, I think, and this is, I think, maybe a difference in the culture of medicine and the culture of public health. I mean, public health has normally been evidence-based. They've normally said, we're not going to do something until the evidence, and then we're going to, be overzealous about it, right? Here they weren't operating off evidence, but in medicine, if we make a mistake, the patient dies. If we cut off the arm and there wasn't an infection, we're the first people to admit we're wrong, and we feel like shit. Right? If I make a mistake in medicine, if I delay in diagnosis, if I miss something, I'm going to feel lousy, and I'm going to want to clear the air, right? And I'm going to want to acknowledge what I did, and I'm going to want to learn from it. That hasn't happened. Maybe what happened was so, I don't know, traumatic to them. So maybe there needs to be sort of they all need to meet with, collectively with psychologists and see kind of what went on with them. But I'm sitting here. I'm not on the right or I'm not on the left. I'm trying to really be in the middle and be neutral and objective through all of this. And there were others like us that were okay. We're not anti-vax. We're not. We're like, okay, let's think about what we're doing. And we were all marginalized.
Yes,
all of
that's
us.
very true. Yeah,
right?
Absolutely. Well, I think Rajiv, that's a good place to end, actually. So thanks so much for the discussion about epidemiology and sort of the failure of epidemiology actually in California during COVID. I think there's a lot of things to pick up here. And thanks for joining us. That was Rajiv Bhatia, who's a primary care physician affiliated with Stanford Medical School and a former deputy health officer at the San Francisco Department of Public Health.
Thanks for having me.